Hi everyone, my name is Rachel Moses and you are listening to the HP Leader podcast. Now this is a series in our COVID-19 Lessons Learnt podcasts, and this one specifically focusing on radiographers and the amazing response they had during COVID-19. I'm delighted to be joined by this panel today, and we're going to have a talk all holds barred about what radiographers do and what they did and continue to do during this pandemic. So I'm going to start off by asking Jim to introduce himself, a little bit about where you're from and what you do, please, Jim.
Hi, I'm Jim. I'm an audit and research radiographer currently working at Mid Yorkshire Trust. I've got a background in CT. I've previously worked in London and Torquay, and I qualified in 2009, and I'm also the author of a book on theatre radiography as well. And I've also been the surgical radiographer in Kenya for a charity organisation a couple of times as well.
Oh, wow. That's quite an introduction. Thanks, Jim.
Oh, sorry.
Amazing. Thank you.
I've just got my CV in front of me here. I'm just reading off.
Love it. Alex.
Hi, I'm Alex. I am the Imaging Workforce Transformation Lead at NHS England and Improvement. I'm a radiographer by background, and I was the lead radiographer at the Nightingale.
Thank you, Alex, and congratulations in your new-ish role.
Thanks.
Tom.
Hi, I'm Tom Welton. I'm a diagnostic radiographer with a background of CT and MR, but I'm now the lead practice educator up at Lancashire Teaching Hospitals, and I'm also the North West Council member for the Society and College of Radiographers.
Thanks, Tom. And for our audio listeners, Tom has the most elaborate background with skeletons and a spine and is in uniform. So he absolutely gets top trumps for that. Thanks, Tom. Bunna, coming into you.
Yeah, I'm Bunna. I'm a sonographer that I work at Guy's and St Thomas's Hospital in London. Worked there for 3 years in paediatrics and general ultrasound. Before that, I was in Newcastle for 5 years, working as a sonographer for a few years, and then before that, a radiographer.
Thank you very much. And last but not least, Steve.
Hi, I'm Steve. I am an inpatient theatre and mobile superintendent radiographer at the John Radcliffe in Oxford. I've had a varied career to get there. I've done some cross-sectional, I've done some interventional, all sorts of things, worked in the north, worked in the south, but now I've landed up pretty much in the middle.
Thank you, Steve. So we have a real diversity of radiographers on the panel tonight, and I'm super delighted about that. And Alex, I want to come into you first. A lot of our listeners and watchers might not even know what radiographers actually do, and I know we've had this conversation before, but do you want to start by giving us a little brief about, where does your degree take you?
Yeah, so radiographers are one of the 14 allied health professionals. There's actually two types of radiographer. So you've got a therapeutic and a diagnostic radiographer. Therapeutic radiographers deliver targeted high doses of radiation to treat cancer. And diagnostic radiographers take diagnostic images with X-rays, CTs, MRIs, ultrasounds to help diagnose and monitor patients with medical conditions. Around 3 out of 4 patients will have an image while they're on their pathway through the hospitals. And with diagnostic imaging, you will find other professions that will acquire images. So you've got sonographers who use ultrasound, you have mammographers who work within breast imaging, you have nuclear medicine technologists who use radioisotopes to look at the physiological processes in diseases. And then once you've qualified and you've had a few years of going through normal X-ray, CTs, and all the different modalities, you can go on and do advanced practice. So we have reporting radiographers, we have interventional radiographers, we have consultant radiographers too. But you also don't have to go in through the degree route. You can go in through an apprenticeship, and we have different tiers. So you can go in through advanced assistant practitioners and work your way up to become a radiographer too. So there's lots of different ways to go into imaging.
Oh, goodness me, I mean, I thought I was pretty clued up here, and I didn't have a Scooby-Doo, clearly. Like, so it's quite a complex profession then. I think, without wanting to offend anyone, the biggest kind of label that you guys get is the button pushers, and I think what people see you doing is taking an image, and I think that's probably the level of doing a scan. So I think that's the kind of image that people have in your head. So I really hope this podcast can help to educate people, not about only the skills that you have, but the interventions that you either carry out or you help support. And one thing, Alex, that stuck in my mind that you said to me at the Nightingale London was, Rachel, there's one thing every COVID patient has in common. And I said, what's that, Alex? And you said, they've all had an X-ray. They've all had at least one. And I thought, that is so true. Because not all of them end up on a ventilator, but everyone has an image. And I thought, that's so powerful. So every single patient, without doubt, encounters a radiographer. So on that note, I want to talk about COVID. And I want to talk about specific roles during COVID. And as part of that, we might talk a little bit more about specific radiography roles, and then either how they've changed or adapted, or how working patterns have changed and adapted. So I want someone to come in and kick off. Maybe I'll come to you first, Steve, and just say, think about the radiographer. So that, you know, either that relatively senior radiographer had a few years under the belt. How did they adapt? How did they function during COVID times? And was there any difference?
It's the grey beard that gave it away, isn't it? So for a lot of plain film diagnostic radiographers, in terms of what we were doing, it didn't change a lot. Still, most departments, you'll find that the most common thing that anybody does is a chest x-ray. We do lots and lots of them. They show up a whole host of pathologies, a lot of them not necessarily connected with the chest, but you get changes in appearance that will show up there. COVID certainly, when it gets to sort of COVID pneumonia, is quite distinctive on a chest X-ray or a CT scan, but on the plain film chest X-ray, certainly for speed and everything else was really important tool for our colleagues in ED, sort of at the front door, in terms of where somebody is in terms of how ill they are. Not always, because we found there were a lot of patients with quite severe COVID that the chest X-rays, certainly to begin with, didn't look particularly bad. That there were other stuff going on. So we're not necessarily changing what we do. The patient demographic perhaps shifted a little bit, in the age range changed a little bit maybe. It was more how we went about it, in that normally your patient comes in, bish bash bosh, and they're out again. Particularly once you get to the more severe end, when people are on ventilators and are on ITU, and then you're going into what our trust called the COVID secure areas. So although the patients have got COVID, then they're just allowed to breathe and cough into the atmosphere, and the staff are protected and are going in and out. So what you'd find is that whereas you could go and knock off a chest X-ray in 10 minutes because that's what you can do, you're having to each time get into the higher level PPE, go into this environment, and it's a very strange environment. It's what you see on films. It's not what you expect to be doing at work, particularly. Certainly not in those sort of numbers. numbers. We're a tertiary centre, so we have an infectious diseases ward, and very, very occasionally you get togged up into all of this kit. Whereas now we're all pretty much doing it every single day with the masks, with the double gowns, with the 3 pairs of gloves, and it's quite a different experience.
Sorry, I just couldn't go on mute there. So one of the things that struck me as well was how I'm thinking back to a time when we were really worried about our PPE supply, and there was a lot of patients needing a lot of x-rays, and I know on some units the radiographers just stayed on some of the units with their portable x-ray machine. I don't know what you call it. Is it a portable x-ray machine? Is that just what you call it? And I just remember, and then radiographers also would help out with things like turns and positioning and proning. And I just remember being this was in the thick of it in the like March, April time. And I don't know if anyone has any experience of that. Alex, I know your team definitely were involved in some of that. So Jim, I can see you. Do you want to elaborate a little bit more on that, about the joint response?
Yeah, I mean, we've always, as a profession, gone and done sort of portable imaging up on patients who are too unstable to move. So you've had ICU patients, sort of post-surgical patients and so on. And it's always been part of the role that we go and we do typically just chest x-rays on them. Obviously, just the expansion in the number of portable chest x-rays that we've done is really a thing that you have to try and get a relationship going with a lot of the ward staff and try and sort of help them out as well, because frankly, we need them to help us out when we're trying to do exams, because we have to move patients around. We have to get image receptors down behind them, or nowadays in front of them if we're examining them prone, which is another trick. And if we can ask them to help with that, then especially if we're around the place as well, because unfortunately, like Steve was saying, imaging exams in ICU and things don't happen as quickly as they do in department for various reasons that are going on. So if we're there, I think it's always just a role to try and help out as much as we can.
Tom, coming down to you, then Alex.
Yeah, just to kind of add to Jim, really, I mean, we saw around about 200% increase in mobile activity purely on chest x-rays. And I think within any hospital, I'm not going to say just my own, but with any hospital, the relationship within radiography and knowing kind of what constitutes a sessional for the PPE and how often we're changing our PPE, going in and out of areas, especially for areas that can't go to the wards like CT and MR, what do we do with these highly infectious patients who do have aerosol generated precautions, and having that fit within the trust. But you've also got highly stressed staff in a highly hot, sweaty, tired lockdown, and you're going in with a hard board wanting to get that x-ray or a series of different people's x-rays, and you're in effect getting in the way of their work. And having that relationship within the areas like ITUs and high COVID wards, it's a very difficult relationship. I think some AHPs where you work within those wards all the time and this half an hour, you're going to have your physio or that sort of situation. But within radiography, you're in and out within 10 minutes, half an hour, and you don't necessarily have that relationship with the wards. And when you're doing that increased by 200%, that relationship is really important to foster. And I think for me, for what I found, is that had to happen within COVID. Otherwise, it would have just fallen all apart, because they all needed their x-rays, they all needed their scans, and recognizing everybody's professional kind of stance and their role within that treatment was quite important for me.
Tom, I love that. I'm going to come back to that in a minute. Alex, over to you.
Well, I was about to just say what Tom said. So that before we went to the Nightingale, we had to set that up. It was in my job at the time. I went back to clinical from a managerial role, and it was making those relationships with the different departments within the hospitals, and making sure that they knew how we could help them, and they could help us. and spending a bit of time on the ward, making sure the layout of the ward, we could get in and out into the rooms, that when they were redesigning A&Es to put like doors on all the cubicles, that we could get an X-ray machine in there, and that they were building areas around us as well as them as well, because the extra space was needed for them to move around the patient anyway. And then when we went to the Nightingale and set it up, it was fostering the idea of we were one team. So if a nurse, if a HCA, if a doctor needed help of doing something, a physio, we were all there to help together, and learning each other's jobs. And it brought me value, because I didn't know what some physios did and what a difference between a chest physio was, and learning about that, and also teaching them about what the different chest x-rays meant and what the different things were. And it became a learning environment, and how we all as professionals are valuable in every single step of a patient's journey, and working together makes that a lot easier.
Thank you, Steve, and then Bunny.
Yeah, I'm just going to say one of the other things that we found very much. So the sort of the COVID staff sort of spread through the hospital, sort of starting with ED and our sort of the infectious diseases ward, and then onto ITU, and then as it spread on, and you've got different staff coming into it. And one of the things that we saw very, very much was supporting colleagues, nurses, physios who hadn't been in the sort of, that hadn't been in the front line to begin with, and spreading along and watching their stress levels go up, and trying to help them with that from a point of view of the sort of, after 3 or 4 weeks, anything, no matter what it is, you get this level of familiarity with it, and so a lot of our colleagues were a lot less familiar than a lot of the radiographers were, because of the role in imaging, and sort of being able to help them in coming to terms with the fact that they were now spending X amount of time in extra PPE and everything else, and it's not necessarily a role that or a position that radiographers necessarily find themselves in, but it was certainly, from my point of view, it was a very almost humbling experience, actually, that you actually know what you're doing, and you can help people come to terms with that sort of stuff, which, as I say, wouldn't necessarily be a traditional radiographic role.
Thank you, Bunny.
Yeah, I just wanted to touch on what Jim said about radiographers and mobile imaging. And when you start off as a radiographer, you do chest x-rays constantly, and that's quite a common part of your job. And then, say in my position, when you go off and specialise in ultrasound, it's not quite as common to go and do a mobile scan on the ward, because one, you don't have the equipment isn't quite as good when you take it to the ward as it is in the department, and it's not quite as portable as an x-ray machine. There are trusts where, and I've worked at some trusts where the sonographers do mobile ultrasounds, but the one I currently work at, we don't really do mobile ultrasounds under normal conditions. But once COVID started, it meant that we had to slightly change our roles, in the sense that the working patterns of all the staff in the radiology department changed. So some consultants were working from home, and the registrars were doing on and off weeks, where they'd be working 1 week and off another week, and there'd be fewer registrars as well. So we'd have to support them in doing the mobile ultrasounds as well. And it makes you realise kind of, so I was quite comfortable with doing them, and the majority of us have a radiography background, so you can use that experience of going to ITU to do a chest x-ray to help you get through that. But having done them previously, I was quite happy to go up and do mobile ultrasounds. But for my colleagues who hadn't ever done mobile ultrasounds before, going up with the registrars was a really good experience for them, because they got to see what they did and kind of take away some of that initial fear that they probably had prior to. Obviously, the use of PPE and having to put on, I had a beard at the time, so I had to wear one of those helmets. I'm not sure what they're called, but they have the fan in as well, where you cover your face with it. That can be quite intimidating, but overall, I think it made a lot of our team realise how skilled we actually are, and how our skills are definitely at the level of the registrars and some of the consultants, and that we don't need to feel that we can't go off and do mobile ultrasounds, because it's something that only consultants can do. And I think that might change our practice in the future, possibly.
Definitely. And, you know, diagnostic ultrasound, POCUS. That's
Sorry?
what they say. POCUS, isn't it? Point of care ultrasound.
Okay, yes, yeah, the A&E staff do that, yeah.
Well, the ICU staff do as well. And I've got, I know POCUS fanatics, like they're obsessed with ultrasound, honestly. So I think you're absolutely right. And physios are definitely jumping on this bandwagon right now. And I think you guys need to mark your territory in that space as well, certainly from seeing some sonographers. So I completely agree with you there. Tom, coming down to you.
Just to kind of encompass what everybody's said, and to add on to that, and I'm not going to do a physics lesson now, but on top of all of those concerns and the learning and the education and the adaptation of your roles, we also had, as a profession, to keep in mind the radiation protection. We had to think about the staff who are spending long periods of time with excess radiology, and there's radiation left, right, and center, and that we weren't set up for the original levels, and making sure that not only the patients were getting the service, but the staff were not having any undue risks to the excess radiation protection around the hospital. It's quite a role.
I'm glad you brought that up, because I've actually scribbled that on my piece of paper, Tom. So radiation, like, I don't want to say you guys are obsessed with it, but
We are.
but this is something that I think is really important to understand. So, and I remember from some of Alex's work and the imaging team, when they were like marking out spaces for some of the like safe zones, safe spaces, obviously the portable scanner units being in basements and things. And if you just think of I'm thinking of the intensive care self, you know, X-ray at bed 5, X-ray at bed 5, back off, back, you know, it was literally. And sometimes radiographers got a bit of a bad name, because we're like, oh my God, they're like, you know, the Gestapo coming in because there's an X-ray in bed 5. But actually, that is consistent. And it's looking after the staff, isn't it? It's protecting the staff. So why is it so important? If you are self-admittedly obsessed, like, who, you know, to talk us through that?
Me? Well, the theoretical is is it 1 in a million chance of getting cancer from every X-ray you have? Which sounds like 1 in a million. Okay, fine. But when you think it's something like 93 million scans and tests were done in England in last year, or something like that, I don't know the exact figures, but when you put it into context, the amount of X-rays we're doing in each hospital, thousands each day, that theoretical risk to anybody, whether it's a staff member or a patient, is always there. And if we've done our job right, then you reduce that risk to the all-time low. I think in normal times, in a non-COVID world, if we can remember that far back now, gone are the times where you'd shout it on a ward and all the nurses seem to get their only break of the day and they never return. And you're like, where have they gone? They're not there to help you get them back off the board. And you can't do that in ITU, I know, and you can't do that now in COVID because you're all scrubbed up. But you then have the same staff for 2 hours on end who may have 8, 9, 10 mobiles within that time easily, and suddenly that cumulative dose to the staff member who's not really being monitored could really increase. And I couldn't live with myself if I knew that cumulative dose was really affecting a staff member who had to be there for the patient. You think about obviously the COVID risk, but the radiation risk is definitely there. although low, and we are mitigating it, and it is a legal right, it is still there.
No, and I remember back to when I did my imaging request training is in my consultant role, which I presume is your boss, Tom. And I just remember thinking, God, it took us about 3 months. It was like being back at university. It was hardcore. And then I got a test at the end, and to make sure I remembered it all. And when I first went into it, I have to admit, I was like, it's just ordering an X-ray. It's really chest X-ray. You know, we're not even talking CT scans here. But then I really started to understand the implications. So thank you. Does anyone want to add anything? Alex?
Yeah, so as radiographers, we have to justify every single dose we're giving to patients. So by having people request them, we have to make sure that the clinical indications match what we're doing, if it's the right test. So we have to look after the staff members, we have to look after our patients, we have to look after if there's anyone with the patients helping them. So with radiation, it's quite a big part of our role. If we work in, still, like MRI doesn't use radiation, and that's a whole different thing. And sonography. But in the Nightingale, you saw me running around different areas with big bits of tape, and that was to make sure that we had enough distance, that staff weren't going to be in the way if we were in the middle of a theatre procedure, walking through, not because it was sterile, but because we didn't want them in the X-ray field, and shouting around, or we had to test big boards to see X-ray on the other side of the wards, because there was no walls. So normally a little bit of wall will help absorb it, but because there was no walls, we had to test to see if the X-rays went through, and how we would tell people once the ward got bigger. So we did have to do shouting tests, or board tests, if we could have lots of people holding boards saying X-rays. But as Rachel found out, we learnt to shout pretty loudly quite easily.
So what about CT scans? These patients needed CT scans, and these patients were unstable, like really sick. And like, can you CT scan someone on the front? Like, is that possible? So who wants to talk us through? Who wants to answer that? Jim, I've seen you nodding there. Can I come into you, Jim? And then anyone else that wants to come in. So how do you make CT scans safe in COVID time? What extra work does it take? And can you scan someone on the tummy?
Well, you can scan someone on their front. It will show up a little bit different. Things will move forward, especially any sort of fluid and things in the chest will all run to the front rather than running to the back. We have to we'll mark down that we've scanned this patient on their front because they needed proning, for example. So it is doable. It's with enough determination, you can pretty much scan anyone that you absolutely have to in CT. One of the big issues in CT, it's not a mobile modality like the X-rays where we're going up onto the ward. So we do have a controlled area for it with radiation protection, shielding, but then we have to move patients down to it as well to have their imaging. So if they are unstable, if they're ICU patient, they're ventilated, or I think a few sites have even had patients coming down who are on ECMO and scanned for CT as well, then obviously you get an entire collaborative team that comes down with them just to maintain their airway and their breathing and basically keeping them alive throughout the scan. That's a really coordinated one. It can work quite well because they're coming into your area, so you can help them out with moving all their equipment and getting and coordinating with them, but they generally are like, okay, we will respect that your area and help you out with your scan. The radiation doses are much, much higher in CT, so we very rarely have anyone in the room with the patients for it as well. So we have done scans in the past where we've had ICU consultants waiting at the door, waiting for the scan to finish just so they can go in and start adjusting the ventilator. There's infection control risks, obviously, with that as well, because if you've got an awful lot of people coming down, they're all coming to your controlled area. So then you have to sort of try and clean down that, and obviously cleaning down the scanner in between patients as well.
Yeah, absolutely. And I certainly know this is when we've done the ODP podcast. This is when ODPs were used a lot for transfer as well, and for stability, being experts in airway and resuscitation, because I don't know if there's a high incident. I don't know if I can say there's a high incidence, but because these patients were so unstable, there was a lot more adverse events going to CT, to the point where it was just, it was, you know, there was a lot of centres that just wouldn't consider a CT scan in a lot of the patients unless it was absolutely necessary, like you said. Tom, can I come down to you, please?
Yeah, just again to add to Jim there, I think we're one of the only areas within a hospital that gives warrant for a COVID patient to travel on the corridors. I think other than going from A&E to the wards and maybe to theatres as well, possibly, the incidences of COVID active patients going down to CT cannot be avoided. It has to happen. And especially if you talk about an ICU patient, 6, 7 members of staff with them to make sure that they're stable. There is always a risk on transit, as we all know. But if they're going to CT, they are the more unstable, they are the more unwell patients, and that is a high risk within that modality specifically. And for me, the biggest issue was the infection control side of things. It's all right in the scanner because you're in a closed off room. Where do you put 6, 7 members of staff who are all PPE'd up? I mean, do you stand them on the corridor waiting outside that can jump back in? Do you put them in a viewing area that has a lot of books and paperwork, and generally where the CT radiographers spend their whole life? I mean, in the ITUs where you have the 2 hours in, 2 hours out kind of situation, well, they go away to a room like their staff room. CT radiographers might do 12 hours in that control room, and you can't have that as a dirty area too easily. So what do you do? How do you keep that as a green area, but then not allow any ITU consultants coming in to see the scans? And the logistics of it was a nightmare. And I don't think some departments have really got to grips with that yet. And I mean, I know there's a lot of infection control departments that don't really know how to class CT scanners, and people are still isolating staff members because they can't make it a green area. It is a bit of a headache, definitely, as an area.
Absolutely. Never even, yeah, that's a great concept to think about. It wouldn't have even been on my radar. Steve, I'm coming to you then, Bunna.
Yeah, just going on from what Tom was saying, one of the problems that you have is that every single department is different. The geography is different. The facilities you've got is different. So you're not even a position for me to ring Tom or Jim and say, how are you doing this? What are you doing that? Because even if you do, you might pick up some tips. You might pick up something, but they don't have the same layout that you do. And so there was an awful lot of making stuff up on the fly in sort of taking what you've got. You've got your gold standard, and I mean, this isn't just through COVID. This is sort of in radiography in general. You've got the gold standard infection control want you to do this, and this. Some of which is absolutely incompatible with what we are trying to achieve and what we've been asked to achieve and everything else. So it's really quite difficult to be able to make hard and fast rules for those sorts of things. Certainly, even hospital wide, never mind nationwide.
Thank you. Bunna, coming to you, please.
Yeah, I was just actually going to talk about what Steve and Tom have just said about with patients coming to the department. We realise we quite often do scans on transplant patients, either pretty much post-transplant or kind of follow-up scans. So we had to come up with a way to protect those patients when they come into our department. So we've issued kind of a red and a amber system where if they are red, they are COVID positive. So we know how to get them down. We tell the porters that they're COVID positive, and they'll be coming straight into the room, be scanned, remain in the room until the porters are ready to take them back and then go back to the ward. And similarly with kind of people who are immunosuppressed, like transplant patients and things like that, they would be on an amber pathway where the ward would inform us that they're on that pathway. And then we'd again get them down, either have them straight into the room or they'd be in the bed bay with no other patients there. And then we'd call the porter just before we finish the scan to take them back to the ward. And that, we found that worked quite well. But what Steve was saying about things constantly changing from the start, our kind of head of infection control nurse for radiology gave us everyone a talk on how things were going to be going in radiology, but it constantly changed, and we found that because they were talking about rooms having a scrub area where you could perform a scan and then go into the scrub area, that's not possible in radiology because the rooms aren't made up that way, and we perform some interventional procedures in the ultrasound rooms as well, like aspirations and drain insertions and things. So we had to speak to infection control and come up with an individual way, and they make guides for us specifically for radiology just on how to perform those scans.
Thank you. Tom, coming into you then, Alex.
Yeah, really quick one. And Boone, you probably know more than I do about this, but I do know more so within sonography than most other modalities, that close quarters kind of working, you cannot get away from being in long periods of time right next to the patient because you have to have hands on the patient. And I think that just adds to the infection control nightmare that was COVID, and having that literally hugging a patient for half an hour with COVID, it's not easy.
Absolutely. Alex.
Just going on the infection control at the beginning, I think I remember back in February, March kind of time when we were still seeing every patient, inpatient, outpatient. There was no real segregation within imaging departments. I know in most hospitals, DGH hospitals, there is one waiting room for everybody. And so you had patients coming in from their GPs, sitting with near inpatients, near patients from A&E who maybe query COVID, maybe really not. Then the infection control, where I was working at the time, policies seemed to change hourly. And we were constantly, did we have to wear this mask? Did we have to wear that mask? Did we have to wear a mask at all? Did you have to wear gloves? Did you have to wear an apron? Did you have to wear full PPE? And it took a long time for everyone to get into the swing of things. But once we were able to segregate patients, we were able and safely. And I know in some departments now it's still quite hard because hospitals were never made to be put in these situations. But the infection control has slowly got better, I felt. But it's within imaging, it always felt that we were kind of the last people to find out.
I bet you probably were, that's why. Steve, coming into you.
Just briefly, I mean, just trying to give people an idea of how quickly things changed, and hourly perhaps not, but we were at the point that if you had 3 days off and you came back and then you just, the emails that came from the first 2 days that you were off with information on what we were doing, how we were changing, you just didn't bother you just deleted them, because literally things would have changed and changed again and again, and they were and trying to get that communication out anyway was just really, really difficult. And it was just 2 days old, I'm not even going to bother to read that.
Okay, so to wrap up, I'm going to ask about lessons learned and planning for second, third, fourth, fifth, maybe surge wave. But first of all, Bunna, I'm going to come into you to kick off this. So I as a physiotherapist, yes, I'm in a leadership role now and very strong advocate for the HPs, but it's fair to say that physios had the media spotlight here in terms of the HPs. And we were doing nothing differently to what we do every single day. You know, we work 24 hours a day, we work 7 days a week, we work 365 days a year, as do radiographers. And I think not a lot of people know that, and not a lot of people appreciate that. I think probably your critical care units do, because they'll always request that 1 a.m. x-ray in the department, maybe. But Bruna, this is your time to really just demonstrate how radiographers adapted to this crisis, and just the opportunity for you to showcase like how amazing you all are. So like just some examples, and how I know you were in a very busy hospital. Guys in St. Thomas's were a very busy COVID hospital. Still are. So yes, over to you.
Yeah, I think as radiographers, and particularly radiographers, I think sonographers early on, we tried to prepare for it in the sense that we cancelled a lot of our outpatient lists and non-urgent outpatient appointments, which meant initially there wasn't very much for us to do. The things we were scanning were very sick patients, COVID patients, urgent outpatients, cancer patients, those things that we normally do. But I think the radiographers, as opposed to the sonographers, were a lot busy at first. But gradually, as time's gone on, and we've realised what kind of we can do in our department, because at first they allowed us to have an extra day from home, just in case we needed it, and then we had to be available to be called in if needed. And that was because there wasn't many outpatients to be scanned. But once we've reintroduced bookings and things have got busier, and it's now becoming back to how it was pre-COVID, but also kind of still doing all the PPE as well at the same time. So it's quite intense. And I think the way radiographers, they kind of go about their thing without any spotlight, and they just have to keep doing things, and they work shifts all the time. So they're doing 24-hour shifts. Whereas sonographers, we do long days, and then sometimes we do weekends as well. Now we're doing a lot more weekends because we're trying to get through the backlog as well. So yeah, I think that's how we've adjusted our working patterns. And in the future, I think we realised that we wouldn't. So during this lockdown, we haven't changed any of our working patterns, and we've kept the same working patterns, and we're not having the day from home because we don't need it at the moment. If things changed, I think our managers have said that we can go back to that if needed. But the ways we can organise workflow, help consultants and registrars do their work so that they frees up time for them to do more CT reporting and MR reporting, because a lot of these COVID patients are having CT scans quite frequently.
Yeah.
It just means that we can do more of their work and cut them some slack, and we're performing at the same level as they are then.
And I think it's probably something that's taken for granted in the NHS, in the acute hospitals. I think it's something that you just know that you can have access to 24 hours a day, and the logistics, like you've all said, about actually performing that x-ray in a red zone, or actually performing that CT on a prone to COVID positive patient, and the implications it then has for other things is quite significant, and how you plan that. So hopefully throughout this podcast we've been able to bring that out a little bit and demonstrate that and raise awareness of that. Tom, I know you want go on, Buddha.
I think so a lot of the urgent things that previously we maybe didn't have space for, so because we've got a cancer centre at Guy's, and we constantly get phone calls every day saying, can you squeeze this outpatient in, who you just don't have space for because there's full outpatients list booked, you've accepted 6 inpatients in for that day. But when we've reduced some of our outpatient lists for the slightly non-urgent things, and when we cancelled the non-urgent things, they haven't been rebooked because it turns out they're fine. Actually, some of those patients, they didn't need the scan in the first place. But it means we are creating more space for things which are urgent, and we're getting a lot more capacity for patients from the cancer centre and transplant patients and things like that.
Thank you. Tom, coming to you then, Alex.
I suppose I'm a forever optimist. To me, like the transition moving forward now, it's about the NHS keeps calm and carried on. We'll do our job, and we did through the pandemic, and we will continue to do that job. That service will be preserved, however stressful it becomes. To me, the lessons learned really revolve around recognition, getting us out of our little dark dungeons of the hospital. I mean, everything that a trust does, they should ask, where does radiology sit in? I mean, I know as a panel we're probably a bit biased to it, and we want as much money as possible, and it is not feasible. But without a COVID situation, we're still seeing 95% of all patients through a hospital. We sit within key areas of major pathways, whether it's cancer, neuro, stroke, most of them. And I think moving forward, yeah, we had a lockdown where most outpatients were cancelled and delayed, and we were COVID focused, but that's not going to happen again. We're now in a position where we've got rising numbers, we're in a lockdown, but actually we've got all the other pathways running again, and although they're not at full strength, they will be, and we cannot continue as we are without the kind of the financial backing, but also the systematic setup for radiology to perform. So not only investment in scanners and machinery, which are very expensive, but also understanding the amount of staff you need within that pathway to provide a service, whether it's in the evening or the night time. And I think if there's any managers are watching, listening, that don't understand that, they need to get to radiology to come down and really understand that we can't just have one person on 2 CT scanners because you've got a major trauma upstairs and an ITU downstairs. You need to have the right amount of staff to be able to provide it, because which one do you delay? Which one do you choose first? And I think that, to me, is where we're moving forward. And we've got the key, like the Richards report, the GIRF report came out, and but also like cancer research and the workforce within cancer reports have all come out this last kind of month or two. And I think nationally they need to recognise, but also the management within hospitals up and down the country need to recognise that we are a key role, and we are an expensive department because £1 million scanners don't pay for themselves. But ultimately, without them, it's going to cost a lot more when you're trying to sort out patients who don't get their stroke services. They don't get their discharge quite as quickly because we can't do their outpatient scan until the next day type thing. So that's, to me, is the recognition more than anything.
And it's the codependent services. So it's your interventional radiology as well. It's things like, feeding tubes, rigs, so radiologically inserted gastrostomies. It's VFs, so video fluoroscopy studies. A lot of them are radiography, SLT combos. So I completely hear you. And again, I think there's probably lack of awareness around that as well. The codependency, one can't exist without the other. Alex, I'm coming into you then, Jim.
So one of the big things that I've learned, I mean, throughout the whole of the COVID first wave, the recovery and going into second wave, I grew as a person and as a radiographer and as a manager. I went into it, I think, quite naively, and I think I was quite a new into my management career at the beginning of the year, and you kind of get into the swing of that. Targets are really important. That's how you drive a hospital. That's how you drive the department. But as it went through, and as I went through the Nightingale and came back out and went off to Barts for a bit, it's your staff, and you can't do anything without your team and making them grow. And maybe I'm a bit biased now because I work in workforce, but it is they are everything, and you can't have an imaging department without your radiographers, your clinical support workers, your advanced practice, your radiologists, your sonographers, everyone in there working together. And we have this brilliant adaptability. So you might be working in intervention in the morning, or the cath lab during PCIs, but you could be going and doing CT and X-rays in the afternoon. It's being able to move about and work in the different departments within the hospital, and being able to adapt your working into different multidisciplinary teams. But I think as a profession, I think now we have to really think about our workforce and how we're going to grow them. It's really hard to to recruit people into radiography because they don't quite understand what it is. So it's giving them that extra buzz from schools into communities, getting our community people that may not really know what it is to go in and do some volunteering, or going in and getting them to if they don't want to go to university just yet, getting them into the apprenticeship roles, and really kick-starting that extra, like igniting that passion that I got when I first started.
Absolutely. And we see that with all EHPs. We need to be better at that, because you don't really know what an OT does as a kid unless you encounter one. It's the same if, a lot of kids have x-rays, don't they? And you just think, well, is that an opportunity when the kid's having an x-ray to give them a leaflet and say, this is what we do. Do you want to be one of us? Every contact counts. Now I'm going to come to Jim, but we're going to start wrapping up, and I want everyone to think about either a lesson learned or a positive point they want people to go away with, because I never like to end these podcasts with me talking. So it's your opportunity to get something across that we've missed, or just basically say, what are you guys doing now? So Jim.
Yeah, I think we have kind of over the years been seen as kind of just a department that happily works along in the background. People put in a nice request and then images show up on packs later on with no thoughts of the actual processes and what happens behind the scenes with that. And I think COVID is probably going to highlight our roles a little bit more, quite how we promote ourselves to the public. I'm not sure. We've got a lot of posters up in our department saying we're radiographers. They don't carry a lot of information other than that and like a little cartoon x-ray. Just going on to the sort of lessons learned aspect, one of the big things I've found is just on a sort of purely practical level is just doing communication with patients, which it's a cliche that it's always one of the most important things, and it is. But especially as we're opening up back to sort of quote unquote normal services on top of the COVID situation, and we're all wearing PPE for so much of the time, that blocks off so much communication that we have with patients. Wearing masks, they can't hear us, you can't see facial expressions and so on. I don't know if anyone wears the hoods with the visors that they let you see your face, but you cannot hear a single thing with those on because you've just got fans going in the back of your head. We've started trying to get some really innovative responses just to trying to sort of communicate with patients who are older, who have hearing problems. We're trying to carry across an awful lot of information in a very short time and to trying to get their exams done quickly. And I think we're getting a lot more development in that and ideas coming through from the staff and the team, which probably wouldn't have happened in previous scenarios.
Thank you. So going to come around to each one individually. Steve, I'm going to start with you because you're on the left of my screen. Go for it.
I don't know really. Like I said before we started recording this, that in a lot of ways my job didn't actually change very much. I am a specialist in doing portable chest X-rays. I did an awful lot of portable chest X-rays. The one thing I did find that I take quite a lot of time in, and it's been touched on by various people. Tom, I can remember saying something about it, that building relationships between departments and interdepartmental working. I actually find that the intensive cares, and we have several of them, they are much more aware of us, that we are considered now a part of the team. We might be a part of a team that flits in and out a little bit, but we are very much part of that team. The bigger problem and is where you don't have the time to build those relationships. The general medical wards where you really are, you turn up with your X-ray machine and you are a pain in the arse, because actually they see you once every 3 weeks rather than 5 times a day. And so from that point of view, the importance that's come out to me of building those relationships with other people and taking the time to talk to people when you have the time. Because if all they ever see is a radiographer that's coming in trying to do 150 things at once and sort of slightly snappy because they're stressed, and it's something that I'm very keen passing on to the newly qualified radiographers and the students. I'm not suggesting you should stand there and have a chat for 25 minutes when you've got 16 people waiting for you back in the department, but actually building those relationships when you have a chance makes life so much easier when you are under pressure.
And it was going back to Tom's point, I think, is AHPs, radiographers and ODPs, like within the hospital environment, are often just left out. There's so much intersectionality between speechies, dietitians, physios, OTs, that I do think we need to be much better at being inclusive as part of the AHP community. And not everyone wants to be part of that, so that's fine. But I think we're stronger together, and I do think we need to just be a bit more mindful of that. And as students, doing more like not joint placements, but just collaborative work on when students are on placement. So going to spend time with the radiographer if you're a physio, going to spend time with the OT, you know, if you're a speechy. I think I completely agree with you, Steve. I think we just need to be a bit better at that.
I trained quite a long time ago, and we had 3 weeks out doing different things with different people, and I can remember the student nurses when I was a newly qualified radiographer. We don't seem to find time in the degree courses for that anymore. Certainly not the students that I see, and I think it's a real loss to everybody's profession.
I'll just jump in quickly. I've just put a bit together about extending student numbers, and I've built interprofessional working into that bid. And my first years, they're going to go to physio, OT, they're going to go to radiotherapy, ODP, so they can get that patient flow but also start the other professions getting an idea of what we're doing. And although they're only first years and don't necessarily have a big knowledge base yet, they have an understanding of what radiography is. And I think we're our own worst enemies at times. We're very good at not having that interprofessional working. So I mean, I'm hoping to write that up as of kind of next year. But the idea that why can't our own students go to other wards for like 1 week, 2 week placements and learn a lot more from that than standing around waiting for X-rays.
Yeah, and when newly qualified staff as well, like give them in 2 weeks part of induction, like go and spend a day with other people, and then you get friends, you see people in the corridor. I completely agree. Tom, let's stick on you then, and then we'll go to Bunna next.
I suppose my point is kind of legitimate around the world, really, but let's stick within the NHS in the UK. What have we learned? What will I be taking for it? I think 2020 has been a very fractious year, to put it nicely. I think it's been a year of healthcare staff and care home staff and anyone that's kind of frontline staff really struggling. I think with not only the workload and the pressures placed upon them, but also the mental health, the anxieties, the stresses and depressions that we all know is increasing within our workforce. And I think for me, it's given everybody that opportunity to talk about it a little bit more, because it's normal to feel anxious and normal to feel stressed. And I think if we embrace that moving forward as healthcare, I think it's a real powerful tool that mental health can actually be a lot more talked about within healthcare. And I think that's quite a way forward now. So it's a positive, I think, that it's now not a taboo within healthcare as much.
Thanks, Tom. Thank you. Bunna, coming to you.
yeah, just touching on the working with other professions, my only reason for knowing what OTs and physios do is because I did a radiography postgraduate course, and we were all closely aligned together at the same time. So we all got to know each other very well. And so we all spoke to each other constantly and talked about our days. And then from then on, we all got jobs in similar hospitals, and then still knew each other, and then could see each other during the day. And that's how I know about what those careers are. But other than that, I don't think you have any other contacts with it. And growing up at school, I didn't know about radiography either, to be honest. I didn't know I was going to be a radiographer. But I think I'll try and sell ultrasound. It's a great profession. You do so many varied things. We don't just scan babies, and I'm going to get told off by our management for not even mentioning that before this. I don't scan babies. So, and you can do vascular, you can do general, and all these different areas. Actually, because the patients who had COVID, even though we don't do chest x-rays and CT chests and things, people who are actually affected by COVID have comorbidities, and so we have to do a lot of abdominal scanning on them, and DVT scans, people because they're spending a lot of time in bed off their feet, not doing as much exercise, they're at risk of DVTs, and that's quite a lot of our scanning as well. So I think anyone who isn't a radiographer or sonographer, there is a radiographer and would like to do ultrasound, I think you should really consider it as a future profession.
Thank you. Jim, coming to you next.
Oh, sorry, I didn't have anything else to add after my point, sorry.
That's okay, thank you so much. Alex,
Sorry.
coming down to you, and I just want to say thanks, Alex, for joining me, because it would have been very strangely for me to have a manel. Anyone that watches any of the other podcasts, I'm a very strong female panels, so I'm delighted to see some gender diversity here. So, so Alex, please, can you finish us off?
So I'd just like to echo what everyone said. We as a profession, we work with every single different department in the hospital, and it's making sure that when we design new patient pathways, when we design new hospitals, which Boris is kindly funding a few more, hopefully, and we can be at the forefront of those planning, but also recognize that as a profession that we can grow we can grow with it. So looking at whether we have radiographers that work in A&E and can help with discharge of minor injury patients, whether if you've qualified as a band 5 and you really love plain film and you go on and you want to become a reporting radiographer, that we make sure that those are always open, and that we encourage our staff to grow within the profession and out into the wider world of AHPs, because until the Nightingale I hadn't really had much work with the wider world of AHPs, and it totally changed the way that I thought and how we were going to grow as a profession. But it is that checking in. It is checking in with your teammates and your friends and the people you work with now. Is, are you okay? Is there anything you want to talk about? Echoing on what Tom said, I think the mental health and the closeness of everyone, how much you've had to work together and the bonds that you've made, that will never change, and it's something that we need to keep and grow as COVID hopefully gets a little bit lighter over the coming years, and keep that. 2020 is going to be a year that we all remember as healthcare professionals, and it's just always having that in your mind. And when you do something and you feel like it's not quite right, making sure you go back to your experiences that you've had through COVID and get the positives out of it.
Thank you. And what a lovely note to finish on. Tom, thanks so much for sharing your thoughts, particularly around health and well-being and mental health. But that's just a really nice concept to finish on. So if you are an allied health professional listening to this, and you're listening to this because you've never really understood the true extent of what radiographers do, can do, and will continue to do, then hopefully this has opened your eyes a little bit and educated yourself. I've certainly learned a lot. And, you know, just maybe think about reaching out to your radiographers, whether you're in a red zone, whether you see them walking down the corridor, whether you are going down to support a patient having a scan, just reach out, ask them if they want to have a virtual catch-up or a socially distanced coffee, because you never know what you could learn. And I just want to say a massive thank you to everyone on the panel and all the radiographers out there. We think you're amazing. We acknowledge you, we respect you, and thank you for your contribution. We are just one team together. Thank you very much.